Hello, and welcome to the CCO Medical Specialties Podcast. I'm your host, Jill Frost. Today's episode features Dr. Ann E. O'Donnell, Professor of Medicine, the Nehemiah and Naomi Cohen Chair in Pulmonology Disease Research and Chief, Division of Pulmonary, Critical Care, and Sleep Medicine at Georgetown University Medical Center. She discusses the latest advances in non-cystic fibrosis bronchiectasis, including current treatment options, data on emerging agents, and how to personalize management strategies to meet patients' needs. This episode is part of a larger educational program titled The Road to Victory Over the Vortex: Innovations in Non-Cystic Fibrosis Bronchiectasis. For more information on Dr. O'Donnell, along with a link to the larger education program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
So, first off, I want to talk about the issue of endothelial and mucociliary dysfunction in this disease. This is a very heterogeneous disease, bronchiectasis. So patients have it for various reasons, but it's almost universal that patients have ciliary dysfunction, impaired mucosal defense at the airway level, and abnormal mucus production for the vast majority of these patients. So, and again, hearkening back to the vicious cycle, vicious vortex, the more mucus, the more impairment of the ciliary function, the more chronic infections. It just goes around and round in this cycle or vortex. And so with that, you get more inflammation, more secretions, and then airway dehydration. And so a big part and one of the foundational treatments for bronchiectasis is tailoring an airway clearance program for the patients. And these airway clearance things can be as simple as just walking, doing routine exercise, deep breathing, yoga for some patients. But then we also have devices like positive expiratory pressure devices with oscillation. We can teach patients various airway clearance techniques like autogenic therapy. We can teach them huff coughing. We can move up to things like hypertonic saline, nebulization, and high-frequency chest wall oscillating vests to move the mucus. This really requires, collaborating with your team, but also with the patient, because the best airway clearance is really the one that the patient has the time and the ability and the willingness to do. So daily airway clearance really is a core feature of treating our patients with bronchiectasis. Like I said, it goes from simple to more complex. In patients that don't necessarily respond or still have retained secretions, despite using things like oscillatory PEP devices, then we generally move up to 7% saline nebulized. Sometimes that's too irritating for patients, and so we'll step it down to 3% physical therapy. But most important when it comes to airway clearance and also just in general in treating patients is really disease education and support for adherence to treatments. So after you've educated patients about the importance of airway clearance, and if patients are still having problems, symptoms, and exacerbations, we want to really start to delve into the infections in the airways. And we know probably about a third of patients, at least in the United States, are chronically infected with Pseudomonas, but 2/3 have other organisms. We know already how many patients have non-tuberculous mycobacterial infections, but also Haemophilus, staph, both sensitive and resistant staph, things like Moraxella, other gram-negatives are what's in the airway. So again, an important take-home message when you're stepping up to thinking about treating the infection is that it's very important to get sputum cultures and on a regular basis so that and the patient knows what organism they're, if they're chronically infected. But Pseudomonas is a bad actor. It causes biofilms. It's been associated with more frequent and longer exacerbations, with more rapid decline in lung function, and more frequent need for advanced therapies like IV antibiotics or hospitalizations. There are different strategies that we take to deal with Pseudomonas. There is the issue of whether early eradication, meaning that when you first identify Pseudomonas in your patient, you might consider this approach very aggressive, wipeout strategy using double gram-negative coverage, either oral ciprofloxacin plus an inhaled antibiotic versus using an IV antibiotic in order to try to quote unquote eradicate Pseudomonas when you first isolate it. There's some controversy about this. Of course, when you first meet the patient, that may be the first time they're getting a sputum. So you don't know if that's really their first isolation of Pseudomonas. But it is very important to approach Pseudomonas and all of the other bacteria in a very systematic management. For chronic management of patients with Pseudomonas, although this is not FDA approved in the United States, we often do reach to using inhaled aminoglycoside antibiotic like tobramycin. Sometimes we'll go to the formulating inhaled colistin. And we're surveilling these patients' cultures routinely, whether or not they're on inhaled antibiotics, to assess how they're responding. One question that often comes up is, when you're on an inhaled antibiotic, does the resistance pattern really matter when you're delivering a high dose of inhaled antibiotic right to the airway? And that's really an area still of controversy, whether that actually makes any difference for the patient. Besides infection, obviously inflammation goes hand in hand with the chronic infecting organisms. And Dr. Griffith already touched on this. Probably about 75 to 80% of patients with bronchiectasis really are neutrophillically inflamed, and they have a lot of neutrophil elastase in their airways, which really leads to progressive tissue damage. One thing to try to avoid in patients with neutrophilic inflammation and bronchiectasis is the routine use of corticosteroids, because it's actually not very effective for the neutrophilic phenotype, and it also can exacerbate the infections. So you want to stay away from inhaled corticosteroids as an anti-inflammatory measure in most patients with bronchiectasis. Although, the caveat is there's probably about 20% of these patients that actually have eosinophilic inflammation in a more asthmatic-y pattern. So what anti-inflammatory therapies do we go to? We use macrolides in bronchiectasis more for their anti-inflammatory and immunomodulatory effects than for their antibiotic effect. So we know that a macrolide strategy can be effective in patients with frequent exacerbations of their bronchiectasis. Emerging therapies to treat inflammation, brensocatib, the DPP-1 inhibitor, with recent phase 3 data that shows reduction in exacerbations in patients treated in the phase 3 and phase 2 trial. There are several other agents being looked at. BI 129-1583, another DPP-1 inhibitor, is about to start a phase 3 trial. But we also are examining the role of the asthma biologics, 33 antibody, in patients with eosinophilic inflammation, and then other elastase inhibitors. And there actually is some interest in phage therapy as well. So really, again, another important take-home message today is the importance of, number one, recognizing bronchiectasis exacerbations, educating patients about when to call you when they're in an exacerbation, which is generally characterized by increased number of symptoms like cough, sputum production, change in their sputum, hemoptysis, increase in breathlessness. We really, really, really want to focus on reducing or eliminating exacerbations. We know that patients who have 3 or more exacerbations a year have a worse prognosis, but really probably 1 or 2 are still significantly bad as well. But really, from our guidelines, 3 or more exacerbations, those patients need to optimize their airway clearance. If they're chronically infected with Pseudomonas, we want to start them on long-term inhaled antibiotic therapy, although macrolide therapy is still an option in those patients. If they have non-Pseudomonas chronic infection, long-term macrolide is definitely an option. And then an inadequate response, you really have to up the game in terms of all of these therapies. So a few caveats, right? Long-term macrolides cannot be used in patients who are co-infected non-tuberculous mycobacterium because you could breed resistant NTM organisms. There are also cardiac and hearing issues potentially with macrolides that you have to take into consideration. So this treatment strategy really does need to be molded to the specific patient. Now, we're excited about the possibility of these new therapeutics. This is the phase 2 data from the Willow trial, which is the bronchiectasis phase 2 study. And what this showed here was that the 10 milligram and 25 milligram dose of bronchiectasis increased the patient proportion of patients who had no exacerbations over the length of this trial. And then the next study, the phase 3 trial, the Aspen study, this again looked at 2 different doses of brensocatib versus placebo. And what it showed was in patients who were having 2 or more exacerbations prior to enrollment in the trial, that there was about a 20% reduction in exacerbations in this very large trial. And the effectiveness held up across various subgroups, including patients from different geographic areas and from who were chronically infected with Pseudomonas. So we conclude that brensocatib, which will be evaluated by the FDA later this year, really does seem to have a significant effect in reducing exacerbations. So more to come on this drug in the near future. So strategies to prevent or slow structural damage. Obviously CT scan doesn't prevent it, but monitoring the CT, and I know this question comes up, how often should you get a CT in these patients? The low dose radiation scans nowadays make these scans much more safe. Really doing routine scanning 1 to 2 years in your stable patients and possibly more frequently in your exacerbators is definitely a strategy. We want to be very aggressive about airway clearance, treating infection and inflammation aggressively. Definite reassessment. I always tell my patients once I meet them, you're my patient for life because bronchiectasis is not going away and we really need to monitor you closely. And another important take-home message I already mentioned is avoiding steroids whenever possible. We want to individualize the treatment based on their underlying disease cause, their endotype, and then on their phenotype, and really aggressively go against particularly the Pseudomonas infected patients, the frequent exacerbator, and look for eosinophilic phenotype in your patients. This shows that some data, there's some observational data. I already mentioned about 20 to 30% of patients with bronchiectasis have eosinophils, and there's observational studies that show benefit to the asthma biologics, but more placebo-controlled studies are needed in this area to understand this better. And we have, fortunately, a whole host of drugs in development. You can see the list here, including the drug ensifentrine, which a study is currently underway in bronchiectasis to look at new options, new therapeutics, and again, approaching the vicious cycle and the vicious vortex at each point in the cycle to break the cycle and improve the patient's condition. So to sum up, again, make the diagnosis as early as possible, educate your patient, assess them for their phenotype, start them on the foundational therapies like airway clearance, and then advanced therapies as needed based on their phenotypical presentation. Here's a patient case, 50-year-old female, chronic productive cough, mucus plugs that she coughs up. She's unintentionally lost 50 pounds. You can see her pulmonary function testing shows an obstructive pattern with moderately reduced FEV1. We send the patient for a CT, and on the CT, what Dr. Brett Elkinger showed us before, the mucus plugging that's more central bronchiectasis with the inhomogeneity of the mucus. And this case really makes you want to check the patient's IgE and Aspergillus specific tests. And as shown previously by Dr. Elliker, really the imaging kind of clinches that this is ABPA. Any comments, Dr. Elliker or Dr. Griffith, about this case?
No, just the CTs, yeah, as you said, pretty typical, the high attenuation mucus and the partly collapsed lung there. So very, very classic. And always remember that bronchiectasis can cause, significant bronchiectasis often causes collapse of lungs. In the middle lobe, there's some partial collapse there, but yeah, pretty typical.
And this is one kind of patient that sometimes really the bronchiectasis can be almost reversed with appropriate treatment of the ABPA. So really important to recognize this. So the bottom line against the cycle of infection, inflammation, lung damage, And we really want to use all of our armamentarium that we've discussed to deal with all aspects of this disease to help our patients.
Thank you, Dr. O'Donnell, and many thanks to you, our listeners, for joining us. As a reminder to view the full program, The Road to Victory Over the Vortex, Innovations in Non-Cystic Fibrosis Bronchiectasis, please click the link in the show notes. And be sure to check back regularly for more episodes on important medical specialties topics.